Okay. We're right. Okay, I guess we probably ought to get going. Good morning, Simone. See you there. Let me just pull up this court case situation today. Okay. All right. Can you guys see my screen? Okay.
Yeah.
Yep. Okay. All right. All right. So we're going to have a more slightly abbreviated conference today because I'm on service. But here we go. So okay. Why don't we start with? Let's start with Perna. Perna. This is a patient I saw in the office who's 11 years old, and this is the electrocardiogram on this patient, and the electrocardiogram computer, ECG computer, says that this is sinus bradycardia with first-degree AV block. And I'm asking the question, do you agree?
The PR interval that's calculated by the computer is 224. I just want to make sure. No, it doesn't look like first degree AV block, because if I look at the rhythm strip on V1, the PR interval is short, then it does not conduct, and then it increases in length. So It's like Wenke block. But then I don't see the pattern throughout, though.
So I agree with you. This is not first degree heart block. So that was good. Any other thoughts on what this might be?
Is it like a wandering pacemaker?
Well, what does a wandering pacemaker mean?
So you see multiple, sorry?
I said, since you used the term, I'll ask you what you mean by it.
You have multiple P waves coming in. So like I see here in V1, very close, the first one, and then there is another one. And then if you see, it is almost overlapping with the T wave in this almost the second and the third complex.
Mm-hmm.
So that's why I felt like, it's giving off multiple P waves.
Well, first thing I would say is a wandering atrial pacemaker is just a term used to denote the fact that when a patient's heart rate is very slow, typically when they're asleep, there can be a small change in the morphology of the P wave, suggesting area of the atrium other than the sinus node that's beating. And it usually is at a very slow rate and is usually considered a benign finding that's actually normal to have wandering atrial pacemaker. But what do you think about the conduction in this patient? So first of all, I would say when you are awake, which presumably was the state of this 12-month-old when she had an EKG, you don't usually have wandering atrial pacemaker. That is almost always something you see in very somnolent or frankly sleeping patients. So this is not wandering atrial pacemaker. And what's going on with the conduction?
So every other P wave is conducted.
Okay, so is there a term for every other P wave being conducted?
Is it like atrial bigeminy?
Well, it's atrial bigeminy if you have a sinus beat followed by a PAC, but it's hard to tell when you have to look on the screen, but the P to P interval in this tracing is fixed. Okay. So let me show you. So this is a V1, which you've referenced many times. And I think it would be fair to say that if you look at the PR intervals, they are not they are not the same. They're changing, right? If you look in this beat, this PR is a little shorter than this PR. This one's longer. And then, as you rightly pointed out, there's a P wave that is superimposed in the T waves, right? And these PR intervals, if you look at them, they're all different. And so what this is actually isosynchronous beating in the atrium and the ventricle in the setting of what is a complete heart block. So if you look at this very quickly, you would have the impression that this is 2-to-1 conduction. But actually, if you look carefully, you see that the RR intervals are fixed and the P to P intervals are also fixed. And so what this is essentially that the atrium and the ventricle are beating sort of 2-to-1. And at least for this strip, it appears as if it's 2-to-1 conduction, but the tell is two things. One, the PR interval is changing. So in a manner that it's not consistent with known conduction. And second is that the R to R interval is very fixed. You know, some of these P waves are long enough after the last P wave, and certainly long enough after the last QRS, that the QRS should be brought in by the P wave. In other words, it should conduct with a shorter PR interval, and the R to R interval should vary. And one of the very important sort of pearls about identifying complete heart block is to look at this RR interval. Although the RR interval will change in patients with complete heart block, on a given strip or a 12-lead EKG, it's unusual for there to be significant R to R variability. And in this strip, you see these calipers are demonstrating that the R to R is very fixed. So this is an example of a child who has a complete heart block with an atrial rate that is essentially double that of the ventricular rate. Does that make sense?
Yes, it does. Thank you.
So that's complete heart block. So I guess what I'm trying to say here is not everything is as it seems, and do not believe the computer on an ECG. I'm sure Dr. Arnon, who's here, has probably changed the interpretation of a computer 8 billion times in her career, reading zillions of EKGs, and certainly I've changed it a lot myself. So, you know, and that actually brings up a good point. What is accurate here, generally? Well, the ventricular rate is usually right on these machines, and the axes are usually right in these machines. And the QTC, which is just a calculation based on the QT and the heart rate, if you agree with the QT interval being whatever the computer measured it at, which I might add is virtually always wrong, then the QTC is correct, because this is just a math problem based on the, we know the Bizet calculation, but always first look at the QT interval and measure it yourself. So you can generally count on the axes being correct on this interpretation, and you can generally count on the ventricular rate being correct. And you can be sure that the calculation of the QT is correct if you agree with the measurement. But all the other things here are generally inaccurate: the QRS duration, the QT, and the PR intervals. So it's always worth, they give you a good gestalt of what's going on, but you want to measure it yourself in all EKGs. Don't trust the computer, at least not today. Perhaps in the future with artificial intelligence and such, I'm pretty sure that's going to get better, and to a point where it's better than we are. But right now we still have stupid machines. Okay. So this is a 10-year-old with palpitations and who had an ablation. And why don't we ask Perna what she thinks is going on here. Oh wait, I just had Perna, so I don't want to torture you, Perna. Sorry. Relax, Perna. Why don't I ask Namrita what you think is going on?
So P wave is inverted in 1, 2, and 3.
Mm-hmm.
It's not sinus.
That's correct. It's not. I agree.
The heart rate's around.
Again, that's an important point, is that, one of the quick ways to tell if you're in sinus is to look at the axis of the P wave. The quickest and dirtiest way is to look in lead 1 and F, looking to make sure it's upright, suggesting that it's coming from an area at least near to the sinus node. It's not a guarantee that it's not another rhythm, but it's very supportive of that diagnosis.
The heart rate's like a little above 100.
Mm-hmm. Intermittently, is it consistently above 100? I agree that, like in this part of the tracing.
Yeah, it's faster there.
But here it's actually a fair bit slower.
Mm-hmm.
Yeah.
So having negative P waves in those leads, he has like a low atrial rhythm.
Mm-hmm. That's true. So what do you think this rhythm is?
The PR intervals are constant. Let's see. Like in V1, you see a pause after the 4th beat.
Mm-hmm. Yeah, I agree with that. It's true. So what we're seeing, so first thing I would ask you is, so this patient had an ablation. I'm telling you that in the statement. Would you tell the parents that the ablation was a success?
Well, we put him in a low atrial rhythm now.
Now, let me just take a step. Let me pause you for a second. When we say someone's in a low right atrial rhythm or a low atrial rhythm, it could be, you could be referring to, say, what Perna was discussing a moment ago, which is sort of like a wandering atrial pacemaker. It's not uncommon, for example, for that alternative rhythm to be a low right atrial rhythm. Remember that we're normally in sinus rhythm because the sinus node has the greatest degree of automaticity in most normal hearts. But if we're not in sinus rhythm, then some other area of the heart starts beating with its own degree of automaticity. Presumably in some patients, it could be in the low right atrium. And so when somebody is very, very sleepy or is deeply asleep, it's possible that the sinus node automaticity will fall and some other area that normally would be suppressed would fire. And that's generally what we refer to as wandering atrial pacemaker. And some people will even call it a low atrial rhythm. And sometimes even when it's low atrial, the PR interval will be short because the focus is coming closer to the area, to the crux of the heart and to the AV node and the His-Purkinje system. But when we see a low atrial rhythm that is not that slow, so in this case, you correctly said it was above 100 beats per minute, maybe even almost close to 150 or 130, we would not generally, you could call it a low atrial rhythm, but is there another term we would use to describe where there's a P wave before every QRS? And it's, this is probably some kind of ectopic atrial rhythm, right? Like an EAT of some sort. And what we're seeing here is patient is having a few faster beats and then slower beats. And now in one lead, it's very hard to tell the difference in these P waves, but I do think you can subtly see that these P waves look a little different than these P waves. I appreciate this isn't a very obvious difference, but as you correctly pointed out, the P wave axis is very abnormal in this patient. And so I think this is basically an example of somebody who probably had an EAT ablation that failed and therefore is having little bursts of ectopic atrial tachycardia. And that is in fact what happened here. This is a boy that we ablated about 6 months ago with EAT, and it was acutely successful. And I saw them in the office a week later, and they were still in sinus rhythm. But then we put a Zio patch on the patient, and we saw a lot of tachycardia, thankfully at a very slow rate, never really much above this rate of about 110, 120. And the patient actually came last week because they were starting to feel palpitations and were interested in a repeat attempt at ablation. And EAT ablations can be very challenging because it's one of the few arrhythmias, right, where a patient needs to be in tachycardia in order to map it. In this case, actually, the patient had a lot of tachycardia. So there really is no excuse that this happened, except that sometimes you can have the ablation catheter immediately adjacent to the site, ablated, and then if it's not right on the spot, then you could have essentially a peripheral injury to the focus. And as the lesion heals, the peripheral areas of the burn will essentially normalize. And so in this case, we were obviously slightly off the mark. And so this patient is going to need a repeat ablation, unfortunately.
So Rob?
Yeah.
This is David. After the fourth beat where there's that pause,
yes.
Is there a blocked PAC in the T wave that you think we're seeing?
I don't think so. I don't know for sure, Dave, but I don't think so. I think this is just I think that, what's different or strange about this, and I think that's kind of what you're hinting at, is that EAT in general usually heats up and cools down. It doesn't usually terminate like this. So you're looking to see if maybe it was still going on, but just maybe the AV node didn't conduct. But actually, I think that the P waves are pretty obviously upright in this lead, and so I don't see anything that looks like that. But it's possible, but I don't think so. I think.
Is it possible that there's injury to the sinus node itself, and then this is just an escape rhythm?
Well, it's an interesting question, and it's not uncommon that when someone's been in EAT all the time, that their sinus node does get a little dopey, as it were, for lack of a better, more technical term. And it is not uncommon that they have sinus slowing, particularly. This is essentially, in ancient times when people would do EP studies and there was no ablation, we would do all kinds of testing in the cath lab during an EP study, mostly because we had nothing else to do because we didn't actually ablate anything. And one of the most common tests done, which is occasionally asked on the boards, is the so-called sinus node recovery time. And when you do a sinus node recovery time, what you do is you're pacing the atrium at a certain rate, let's say a rate of 100 or cycle length 600, or a rate of 150, which would be a cycle length 400. And you're pacing for, say, 30 seconds, and then you come off pacing suddenly, and you wait to see how long it takes for the next P wave, the sinus P wave, to come back. And there are actually normative data for people on how long it takes for the sinus node to come back. And if it comes back longer than that, then we would say that's evidence for sinus node dysfunction. And that's a demonstration of the fact that you can temporarily suppress the sinus node by anything else that's going on in the atrium. We've talked in this conference before that when it comes to rhythm, whatever is the fastest wins in the heart. And so when you're just like with pacing in a sinus node recovery test, if you're in EAT at a rate of, say, 120 or 130, it will suppress the sinus node. And when the rhythm stops, there will often be a pause. And so is this a sinus beat, or is this an ectopic atrial beat or a low atrial beat? It's hard to know, except to say all the leads are simultaneous. And it is at least suggestive, looking at these leads, which look to be the non-tachycardia beats, that the P wave axis is correct. So I'm guessing that these are actually sinus beats all, and these are EAT beats around it. But I'm not 100% certain. So he's going to need another EP study, unfortunately. And as is the case in New York, they've gone for 700 opinions, but thankfully they have decided to come back to the original person who failed, which would be me. So we'll see if we can take care of this for good now. Okay. So why don't we go to Sanjeev Gupta of Hackensack, New Jersey. This is a 10-year-old whose mother has a history of lupus and is in my office for a follow-up. What do you think is going on here? I should mention that I try to have themes occasionally in talks. I'll use that as my hint.
bradycardia, the heart rate's around 40.
Mm-hmm.
and it does look like it's in sinus rhythm, and there's a P wave before every QRS. The PR interval is changing. So looking at the rhythm strip at the bottom, it almost looks like the PR is getting shorter. And then there's also extra P waves that aren't conducted. So
happening with the R to R interval?
That looks pretty constant. So maybe we could do what you did on the first patient and see a clue that there's a stable R to R interval and the P to P interval. I guess is a little bit harder to notice, but it probably also is also stable. So this could be a complete heart block as well.
Yeah, so this is an example of also of complete heart block. So the patient is 10, has congenital complete heart block in the setting of lupus, which we know, of course, is not uncommon with a maternal history of lupus. So how are you going to determine in your office, how are you going to decide when it's time for this patient to get a pacemaker? Right, because this is a heart rate of, I believe the rate was in the 40s, mid to high 40s. So what do you want to, how would you make this decision?
So the first thing you could ask him if he's having any symptoms, if he's having any pre-syncope, syncope, or any kind of symptom that would prompt you to put a pacemaker in. That's
very, very important, absolutely. And in this particular case, the patient is actually saying that there are no symptoms.
And then I guess the other thing you would do would make sure that when they're sleeping that, it doesn't go lower. So you'd want either a Holter or a Zeo patch, probably something longer than 24 hours maybe, and see what the lowest his heart rate goes when he's sleeping.
Right. So, right. Although the lowest they go is not that important. I'm going to just interrupt you. Dr. Fink, who's on the call, who I don't know, but thank you for joining us, is making the comment that the P to P interval is not exactly fixed. And in fact, some of these P waves are a little early. So it is possible that this could be some kind of atrial bigeminy with blocked PACs. However, the tell here is that the PR interval on the non-PAC beats is actually varying and is not bringing in the QRS. There's a fixed R to R interval. So she is correct. This could be atrial bigeminy with a complete heart block. So that's a good observation. Thank you for that. So you were saying, Sanjeev, that you would look at the Holter and see how low the patient got. That is true, you would, but is there anything in particular that you would look for in terms of how low the heart rate got?
I guess you'd want to see like the morphology and see like what the escape is. Is it ventricular escape? Is it a junctional escape? Like here, the QRSs look pretty narrow. So
right. So you're referencing whether the QRS is wide or narrow, and that's actually quite accurate and correct. So I'm just going to pull up here. These are, in fact, the formal ACC and AHA recommendations for pacing in patients who are children who have heart block. So let's go through the class 1 indications. So advanced second or third degree AV block associated with symptomatic bradycardia, ventricular dysfunction, or low cardiac output. So that actually was the first question you asked, Sanjeev, which is, how's the patient feeling? Is there any evidence for low cardiac output based on clinical symptoms? I will tell you in my personal experience, it is very rare that children with complete heart block, at least young children, are symptomatic. It is certainly possible, and it is certainly always a question to ask, but it always seems to me that the parents of children with complete heart block, if anything, overstate how energetic their children are for whatever reason. Sinus node dysfunction with correlation of symptoms during age-inappropriate bradycardia. And so if you have very slow sinus node, and are very bradycardic and symptomatic. Again, something that is uncommon in a structurally normal heart. Occasionally you will see it though in Fontan patients or post-op patients. Postoperative advanced second or third degree AV block that is not expected to resolve or persist at least 7 days after cardiac surgery. And we've talked about how complete heart block or high-grade second-degree block following congenital heart surgery is associated with a small but not zero risk of sudden cardiac death, and why we, after about 7, I think it's actually by 8 or 9 days, it's about 98% of patients, 98% of patients will will resolve or not. Congenital third-degree AV block with a wide QRS escape rhythm, complex ventricular ectopy, or ventricular dysfunction. So that speaks to the comment you made, Sanjeev, a moment ago, which is you want to look on the ECG to see if it is a wide QRS or a narrow QRS escape rhythm. And so that is one of the reasons we would do a Holter in a patient like this, or a Zio, or some kind of a monitor, because we want to see when the heart rate gets slow. So it's not the absolute rate that it gets to so much as when it gets to that lowest rate, are you seeing wide QRS escape beats? Because that is in fact what is worrisome about having complete heart block. Is the theory is that you get so slow that you have wide QRS escape beats that could potentially trigger VT or VF. So when you start seeing wide QRS escape beats in the setting of complete heart block with a very slow heart rate, you would get at least a little concerned. Congenital third-degree AV block in the infant with a ventricular rate less than 50 to 55, or congenital heart disease with congenital heart disease, and or with congenital heart disease, a ventricular rate less than 70. So in other words, we would allow up to 50 to 55 for an infant, and with a structurally normal heart. And if you had congenital heart disease, anything less than 70, we would not. That is presuming someone who did not have surgery. And then finally, pause-dependent VT with or without a prolonged QT. So there are people who have pauses and develop VT. That would be an indication for pacing. Now, so these are all the obvious ones. These are the ones that if you live in the United States and you don't do, you could put yourself at medical legal risk. Now, these are the class 2A indications, meaning that most people would agree this is the right thing to do. If you don't do it, you're not a terrible person or doctor, but most of the time we would do that. Alejandro Lozano is asking if you had an ASD with complete heart block, would that be enough? I think it's an interesting question. I don't know that they were thinking that sophisticated in this when they were making this, but I assume your point is simply that an ASD is such a minor hemodynamic burden that maybe we could be more allow lower heart rates. I think I probably would, in that circumstance, allow lower heart rates. And the reason I would do that is because of all of the issues associated with pacing small children. So the class 2A indications are Brady-Tachy syndrome with the need for long-term antiarrhythmic therapy other than DIG. Okay, although generally speaking, I feel like if you have so much tachycardia that your antiarrhythmic therapy is so intense that you need to put a pacemaker in, probably you need to ablate that arrhythmia. The next is congenital third-degree AV block beyond the first year of life with an average heart rate less than 50. Abrupt pauses in ventricular rate that are 2 or 3 times the basic cycle length or associated with symptoms of chronotropic incompetence. So this gets back to the Holter and why it is important to do a 24-hour or longer monitor in these patients, because this is in fact a 2A indication, which is after a year of life, when you are structurally normal, if your average heart rate is less than 50. So we'll come back to our case in a moment to see what the average heart rate on my Holter was. Long QT syndrome with 2-to-1 AV block or third-degree AV block. These are usually long QT type 3 patients, or the sodium channelopathy, amongst the worst types of long QT. I hope people who are in this audience don't have many of these patients. They are very challenging. Asymptomatic sinus bradycardia in the child with complex congenital heart disease with resting heart rates less than 40 or pauses in the ventricular rate of more than 3 seconds. And the assumption here is that this is bad for your heart and also puts you at risk for VT. And then finally, patients with congenital heart disease and impaired hemodynamics due to sinus bradycardia or loss of AV synchrony. So getting back to this child, I did his annual Holter, and this is one of the reasons we do a Holter. So the Holter is telling you 2 things of importance. One, are you having these really long pauses that the AHA says are an indication for a pacemaker? I guess there's 3 reasons. 2 is to look for wide QRS escape beats that are also a 2A indication for a pacemaker. And then finally, to look at the average heart rate, which in this case is 48. And you recall that according to this, if you start to see a heart rate that is less than 50, you should consider a pacemaker. Now remember, this is a 2A indication, meaning it's recommended, but it is not sort of required. It's sort of, I think 2A generally means most authorities would do it. So I have known this patient for only 1 year, but because the heart rate has been pretty much fixed at 49 or 48, I have elected to wait because the child is asymptomatic, is very close to the cutoff, and is small for age. And remember that the choices are either epicardial pacing or transvenous pacing. And when we put a transvenous lead in a small child, of course, the lead is relatively large compared to the size of the vein in which it is being placed. And so by definition, you are risking the possibility of venous occlusion. And remember that a patient with complete congenital heart block is likely to need lifelong pacing. And so if we can put off pacemaker insertion until the child is closer to adult size, there may be some technical benefits for the patient going forward in terms of ease of pacing in the future, need for extraction. Also remember that if the child is, say, 4'7" or 4'8" at age 10 and ends up being 6 feet tall, we cannot put 6 feet height worth of lead in the heart with growth. I mean, we can try, but there is a limit to how much excessive slack and lead you want to put in the heart. And so if you put a transvenous lead in too early, you're virtually guaranteeing that the patient is going to need an extraction, which carries its own risks. So in this asymptomatic, structurally normal heart patient with normal heart function, with no wide QRS escape beats and no long pauses, I have decided to continue to watch this patient, and I see him every 6 to 12 months now. Since I have like 2 or 3 Holters with a very similar average heart rate, I'm going to see him again in a year, but I have, of course, given the family anticipatory guidance regarding how they feel. In my experience, once children reach adolescence, you start to get some complaints of being more tired. And it's fascinating how even in the patients who are asymptomatic, when you put a dual chamber pacemaker in them, they virtually always will tell you afterwards how much better they feel, and they didn't actually realize how run down they were until they were no longer feeling that way. Okay. All right, Neha Walia. This is a 5-year-old with a history of SVT in the emergency department. This is, in fact, what I was told by the referring physician. So I'm just repeating to you the message I received at 11:45 p.m., the favored time to contact me with any arrhythmias. And I'd like you to look at this and tell me what you think.
So this is narrow complex tachycardia. The heart rate is over 250.
I might add that the patient is fine hemodynamically, doesn't feel great, but is, sitting in a bed and has an adequate blood pressure.
Has not had a good blood.
No, has an adequate blood pressure and looks and feels okay.
Okay.
But it's clearly feeling palpitations, which is why the child is in the emergency room.
Got it. So in lead 3, at the end of the QRS, I think there are blips which maybe retrograde P waves. And this is a 5-year-old. So I'm thinking tachycardia, if these are actually retrograde P waves, then this will be a a long RP, and would be some sort of AVRT.
So let me stop you. First of all, I know I've used the term, and so you're just saying something I've told you, and I want to be a little more accurate. When people refer to a long RP tachycardia, they usually mean a very long RP, like an RP of like 200 milliseconds. I know that what you mean is that the R to P interval is greater than 70 milliseconds, and so that's the line in the sand that we traditionally use to distinguish between AVNRT and orthodromic reentrant tachycardia. I assume that's what you meant. Is that right, Neha?
Right.
Yeah. So it's not wrong to say it's a longer RP because you meant longer than 70 milliseconds.
Longer than 70, yeah.
Yeah, but really just as an FYI, when you read in textbooks or when you talk to other doctors in EP, typically, when we say a long RP tachycardia, we're talking about a very long RP, like 200 milliseconds. And in those cases, we're thinking about diagnoses like PJRT, or sometimes EAT can be thought of as being a long RP or look like a long RP. But I understand what you mean. But let me ask you something. This axis, the first statement you said is this is a narrow QRS tachycardia.
Now that I'm looking at it, in like V1, like the precordial V1, V3, they look whitish.
I would say more than whitish. I would just use the term wide.
Yeah, they look white.
Okay.
Yeah.
Okay.
But
anything else unusual about the morphology or the axis of the QRS?
Yeah, so it looks like in the precordial, it's sort of like a right bundle branch block sort of morphology. And it is up in one and down in AVF, so it's left axis. So is it like the typical Bell-Hansen with VT?
Right. Right. So I've told you what the doctors in the ER thought. Let's see if you were right here. So this was the rhythm strip of the same patient. You can see the lovely, we're now at about, well, you can see on the strip, it's 12:05 a.m. now. And then the doctors gave adenosine, and you see a little bit of slowing and sputtering in the rhythm, but you could see it just sort of started up again.
Right.
And so this is an example, as you said, so what are you going to do? This is actually an example of Bell-Hansen's tachycardia, or an LV outflow or fascicular VT, which typically respond to IV calcium channel blockers like verapamil or diltiazem. And so again, I would just remind you that when you see this pattern, this is a very classic pattern of Bell-Hansen's or LV tachycardia. You should sort of try to put this in your brain, because this business with the adenosine was just a waste of time, really. And the reason it's important to know this is because we would not normally give a calcium channel blocker to anybody else who has VT. That is not an appropriate treatment of VT normally. This is actually, so we decided to give diltiazem in this case. We gave 0.25 milligrams per kilo and then started an infusion. And this is what the electrocardiogram looked like. And I would point out the fact that the QRS is narrow in this patient when they're not in tachycardia, and also has a normal axis, okay? Remember that the QRS was downgoing before. Now, is it possible that what we were looking at was possibly aberration of SVT? It's possible, except the axis is completely different. Remember, in SVT, usually the QRS axis should be the same as in sinus rhythm, and the morphology is very different. So what is this Bell-Hansen or fascicular verapamil sensitive VT? Typically, it's classically a right bundle branch pattern with the left axis deviation, which you made that diagnosis, Neha, and that's correct. It's typically seen in young, healthy patients, with the first episode often during adolescence, and this was an adolescent. The episodes may be precipitated by exercise, excitement, or infection. So in this present era where we're worried about COVID, it is conceivable that a COVID infection could have triggered this, but COVID infections don't cause you to have vesicular VTs, but it might induce an episode in someone who already had the substrate. The symptoms are usually palpitations, dizziness, fatigue, and importantly, patients with Bell-Hassan VT are usually very hemodynamically stable and have a heart rate that's very similar to SVT. And so that's the reason why the doctors in the emergency department naturally thought this was SVT rather than VT. You know, we often think that if you're in VT, you're basically on the verge of dying and arresting, but in fact, hemodynamically, this type of VT, as well as RV outflow VT, are usually very hemodynamically well-tolerated arrhythmias. This rhythm can transiently stop with IV adenosine, so the fact that there was a brief, maybe sputtering or pause in the tachycardia did not rule out the possibility that this was a verapamil-sensitive VT. And importantly, it's extremely unusual in someone with a structurally normal heart for this to cause either syncope or sudden cardiac death. This arrhythmia behaves clinically more like an supraventricular arrhythmia. It's not to say it couldn't be potentially more life-threatening, common. And so the treatment for this is traditionally either verapamil or ablation. I have had examples of cases where patients have had this 2 or 3 times and then they stop having it. So I don't run to ablate these patients because sometimes they just stop having it. Now, you might ask the question, why did we use diltiazem in this case rather than verapamil, which is the more standard treatment? And the reason that we did that was, or I chose to do that, was because verapamil is very hemodynamically embarrassing, causes a lot of hypotension. And in the intravenous form, it comes very concentrated, and it's very difficult to give verapamil slowly. I'm sure Rika remembers the era when there was no adenosine, and you had to use verapamil to terminate SVT, and it was hard to do because you'd have to give it over a very long period of time, like 20 or 30 minutes, because of concerns that you'd get, hypotension from it. I've actually given it to one patient who arrested with it because, an older child, because it was given very rapidly. Diltiazem is less hemodynamically embarrassing, has similar properties, and quite frankly, I wasn't sure it was going to work, but it worked quite nicely in this patient. And so we put that patient on a diltiazem drip and eventually transitioned over to, actually I put him on a beta blocker and we'll follow this patient as an outpatient in Brooklyn. But I think this pattern that is a very important one that I would definitely recommend you sort of try to keep in your mind's eye, because if you practice pediatric cardiology long enough, you will see one or two of these patients. And, you want to be the smart guy who figures this out and doesn't do this. I think that's a very nice case of Bell-Hassan's. Okay, the next one I was going to do is actually an EP study that we did last week. I think probably since it's 7:45, we're going to stop now because we have conference and I'm unfortunately on service this week. So I think we'll stop for today, and maybe next week we'll review the intracardiac tracings of an interesting ablation that Perna and I performed on Friday last week. So thank you everybody for joining the call. This was fun. We'll put this up on YouTube later in the day, and we'll be back next week on Monday morning, and we'll see you then. Thanks so much.
Thank you.
Thank you.
Thank you, Dr. Pass.
Thank you. Okay. I'll get out of this. All right. Take care. See you, Sir K. See you in a few weeks.